Now that we've discussed the typical features of autoimmune arthritis and connective tissue diseases as well as vasculitis, we can now talk about other autoimmune diseases with various etiologies. Sarcoidosis is a multi-system autoimmune disorder characterized by the presence of granulomas and granulomatous inflammation. Disease onset is typically in middle age, and it can affect various ethnicities, including Caucasians, where it tends to have milder disease, as opposed to in African Americans, where it tends to have more severe disease. Pulmonary sarcoidosis is the most common manifestation, which is characterized by the presence of hilar lymphadenopathy and, in advanced disease, fibrosis of the lungs. Other typical manifestations include a nodular erythematous rash, known as cutaneous sarcoid, lymphadenopathy, particularly in the hilar regions, but also anywhere throughout the body, and uveitis. Sarcoidosis can also affect other organs such as the liver and rarely the kidneys as well. Manifestations of sarcoidosis may develop over a long period of time, or it may present with an acute sarcoidosis flare, where the acute form of sarcoidosis is known as Lofgren syndrome, presenting with fevers as well as typical manifestations of particularly pulmonary sarcoidosis. A angiotensin converting enzyme or ACE level can be done, and an elevated level is suggestive of sarcoidosis, as activated macrophages and epithelioid cells that form and surround the granuloma increase expression and production of ACE, leading to elevated serum levels when there is active disease. However, ACE, relative to other tests, does not have very good sensitivity or specificity, and so a negative ACE does not rule out sarcoidosis, especially if there is low disease activity. Other non-specific markers of sarcoidosis include an elevated 1,25-hydroxy vitamin D3 level. Also, because the surrounding epithelioid cells do increase production of 1-alpha hydroxylase, which increases the conversion of 25-hydroxy vitamin D3 to 1,25-hydroxy vitamin D3, hence the elevated serum levels. As a result, they can then be increased calcium reabsorption and therefore a elevated calcium level as another non-specific marker of sarcoidosis. A PET scan can be used to show increased disease activity, particularly in the lymph nodes, which can suggest sarcoidosis, but ultimately the diagnosis is best made with a biopsy showing non-caseating granulomas. This is often necessary because the key differential diagnoses to the presentation for sarcoidosis include things like tuberculosis and lymphoma, which can have very similar presentations to sarcoidosis and need histological confirmation to secure the diagnosis. There are no autoantibody tests that are specific for sarcoidosis because it is not thought to be an autoantibody-mediated disease, unlike the other autoimmune arthritis and connective tissue diseases that we've discussed. The other important autoimmune disease to discuss is that of rheumatic fever, which can be an autoimmune complication of streptococcal pharyngitis, typically affecting the pediatric population. This disease is thought to arise because of molecular mimicry, where, as part of the immune response to streptococcal infection, antibodies are made against particular streptococcal antigens, including streptococcal M protein, which has a similar structure to human cardiac myosin. This therefore leads to molecular mimicry and can result in cardiac manifestations from rheumatic fever. Other manifestations include that of a migratory polyarthritis, Sydenham's chorea, erythema marginatum, and subcutaneous nodules. And these typical features form the Jones criteria, which is the diagnostic criteria for rheumatic fever. Typically, there must be evidence of a streptococcal infection, particularly a streptococcal pharyngitis, preceding the onset of these typical rheumatic fever manifestations. Streptococcal infection can either be confirmed by a throat swab or with elevated ASOT or anti-streptolysin O theta, or an elevated level of anti-DNase B antibodies, which is more sensitive than ASOT for streptococcal infections. Streptococcal infections can also result in severe renal failure from post-infectious glomerulonephritis, and the diagnosis of this can be confirmed with renal biopsy showing crescentic glomerulonephritis. I'd now like to talk about the autoinflammatory diseases, which is a relatively rare group of diseases which can have similar manifestations to the other autoimmune diseases which we've discussed in the previous videos. Firstly, there are a group of autoinflammatory disorders which are known as the periodic fever syndromes. These typically occur in the pediatric and young adult population and arise because of genetic mutations leading to antigen-independent activation of inflammatory pathways, particularly the inflammasome pathway, which leads to IL-1 production, and activation of NF-kappa beta. The result is uncontrolled, almost constitutive activation of these inflammatory pathways, which leads to fevers and non-specific symptoms associated with the inflammation. Patients can have very high elevated inflammatory markers, but do not have any other positive autoimmune serology on investigation, and extensive workup for infectious etiologies are unremarkable. The diagnosis of a periodic fever syndrome in the right clinical context can be confirmed with genetic testing. For example, by detecting mutations in MEFV, which is the gene responsible for the production of pyrin and results in familial Mediterranean fever, perhaps the most well-known of the periodic fever syndromes. Because these diseases result in hyperactivation of the inflammasome and IL-1 pathway, effective treatments include medications that can block this pathway, particularly anakinra, which can inhibit IL-1, and colchicine, which is a microtubule inhibitor and can prevent the formation of the inflammasome. Another important autoinflammatory disease is that of adult-onset Still's disease, which is characterized by the presence of fevers, severe arthralgias, and a typical salmon-colored maculopapular rash. There can be markedly elevated inflammatory markers and leukocytosis as a result of the systemic inflammation. Autoimmune serology, including rheumatoid factor and ACPA, are typically negative in Still's disease. A similar autoinflammatory disease is that of hemophagocytic lymphohistiocytosis, or HLH, which can either be primary, having a genetic cause for autoinflammation, in which case disease onset occurs early in life, or HLH may be secondary to underlying autoimmune and hematological diseases, and hence present later in life. The hallmark of HLH is that of abnormal macrophage activation and a cytokine storm, which can lead to markedly elevated inflammatory markers and fevers as symptoms of systemic inflammation. Typically, the ferritin level is markedly elevated, more than about 3,000 nanograms per ml, but can be much higher, such as greater than 10,000. There can also be associated hypertriglyceridemia, hypofibrinogenemia, and an elevated soluble IL-2 receptor alpha level. The diagnosis can also be made from histology or bone marrow biopsy, where hemophagocytosis, or macrophages phagocytosing red blood cells, can be observed. Peripheral blood cytopenia can also be a prominent feature, particularly anemia, thrombocytopenia, and neutropenia. And lastly, I want to touch on a relatively recently discovered autoinflammatory disease known as VEXAS syndrome, which stands for vacuoles, which can be observed in cells from bone marrow biopsy, E1 ubiquitin activating enzyme, which is encoded by the UBA1 gene, which is the gene that is affected in this syndrome, X for X-linked, because UBA1 is located on the X chromosome, A for autoinflammation, and S for somatic mutations. Given that the UBA1 mutations are acquired and not inherited. VEXAS tends to affect males more than females and has disease onset in middle age. Typical manifestations of VEXAS syndrome include polychondritis, neutrophilic dermatoses, vasculitis, myelodysplastic syndrome, and cytopenias. Like the other autoinflammatory diseases, the manifestations intersect the specialties of rheumatology, hematology, and immunology, as well as other autoimmune diseases with various etiologies, including the autoinflammatory diseases. We can go on to discuss the approach to working up autoimmune arthritis with a focus on autoimmune serology.